Hello, everyone. Thank you for tuning in with me tonight. I would like to take a moment today to discuss with you airway management and cardiac arrest. When a patient collapses in cardiac arrest, we have a very limited time window to make a difference, and that window is about 600 seconds, or 10 minutes if you did the math. And the evidence is clear and consistent. High-quality continuous CPR and early defibrillation are the two interventions that are most strongly associated with survival. And that's exactly why the American Heart Association shifted from the traditional airway breathing circulation approach to the CAB, where compressions are first, followed by airway second, and then breathing. And with this shift in airway management to the second position, it's raised an important question, which is what is the best airway strategy for cardiac arrest, especially when every second and every interruption in chest compression matters. And this is often a very emotional topic. For many of us, myself included, value endotracheal intubation. It's a skill we've worked hard to develop, and it's something that we take a lot of pride into. So when it's questioned as to if it's the best airway management, it makes us all kind of take a deep breath for a little bit. But remember, this isn't about us, and it's about our patients. And when we look at the data objectively, it tells a clear story. Multiple randomized controlled trials, including the PART trial published in the New England Journal of Medicine, have shown no improvement in survival when comparing endotracheal intubation to supraglottic airway and out-of-hospital cardiac arrest. In fact, evidence suggests that repeated intubation attempts can be harmful, and in 2021, a study by Murphy et al. Demonstrated a 59% decrease in survival with each additional attempt at intubation beyond the first attempt. And when we look at our system, our documented first pass success rate is around 70%. And realistically, I believe it may be lower because not everyone is documenting every attempt in the PCR. This means a significant number of patients are exposed to delays and interruptions in chest compressions during one of the more critical moments of their care. And at the same time, we know that for every minute delayed in defibrillation of a VTAC VFib rhythm decreases the patient's survival by 10%. And going back to the beginning, continuous compressions are essential, and interruptions, even brief ones, matter. So we have to ask ourselves, are we focusing on the right priorities during cardiac arrest? Unfortunately, we have some national guidelines that help dictate what the best practice is. And the National Association of EMS Physicians, in its evidence-based meta-analysis of airway management guidelines led by Dr. Jeff Jarvis, provides very clear direction. It states, in adult cardiac arrest, either bag valve mask or a supraglottic airway is appropriate, with no demonstrated survival advantage to endotracheal intubation. And in cases of pediatric cardiac arrest, where respiratory causes are the most common cause of cardiac arrest, you should start with bag valve mask ventilation and then progress to a supraglottic airway if needed. And rarely is endotracheal intubation required. These recommendations reinforce what we already know in the broader literature is simpler, faster airway strategies that minimize interruptions in chest compressions are not inferior and may be safer in most of our patients. So what does this mean for us at Bradley County EMS? Well, Jada and myself have taken the time to train Bradley County Fire Rescue and soon Cleveland City firefighters on the placement of iGels. And as it stands right now, if you've been properly trained and you have a licensure at the EMR level or above, it is appropriate for you to place an iGel in cardiac arrest. So, based on the evidence and in alignment with the national guidelines I just spoke about, we're making a change. Effective immediately, iGels will be the primary airway in all cardiac arrest patients. This approach allows for rapid airway placement by fire personnel, leading to continuous chest compressions, only stopping for AED rhythm analysis and pulse checks. And this frees our paramedics and advanced EMTs once they arrive on scene to obtain IV access or IO access if you're advanced EMT and continue with the medication administration and monitor CPR quality. However, if you are a paramedic, you get the second most important thing, which is rhythm identification and early defibrillation. The second thing that we know changes lives. So I know that I'm going to get the question with all of this, that is, Well, if we do all this great and we do the continuous CPR and we get the early defibrillation and we get ROSC on the patient, should we go ahead and intubate them at that time? And I think the answer to that question is no. And here's the reason. As we know, these patients are very hemodynamically unstable and are at very high risk for repeat arrest. So we should take this time, since we have a working advanced airway in place, to manage the patient's hemodynamics. And maybe this is done through push dose pressors or IV fluids if we need them. Or maybe if we just have an IO, we obtain IV access. And what we know is giving these patients more time makes them more and more stable. So in our average 8 to 11 minute transport time to the hospital once we retrieved ROSC, we are buying the patient time. For when they arrive to the hospital, they're much more stabilized, and it's much more safe for them to undergo endotracheal intubation without the risk of hypoxia and hypotension. And if you need to give medications at the hospital to help improve hypoxia and hypotension prior to RSI, you have time and you have staff and you have a more selection of medications to help make this more safe for the patient. Keeping this all in perspective, I want to give you a little bit of data on this. When you look at the number needed to treat, which is a number to determine how many times you would need to provide an intervention to get one survivor, with epinephrine, it's 1 in 412, meaning you need to give 412 additional doses of epinephrine to get one survivor. But when you look at early defibrillation, it's 1 in 4. So that just shows you the significance of what happens when you focus on the things that truly matter, which is continuous chest compressions and recognizing VTAC VFib and providing early defibrillation. So in summary, iGel is now the primary airway in cardiac arrest, and still our focus remains on continuous high-quality CPR, early defibrillation, and minimizing interruptions. Having this advanced airway in place now allows our firefighters to do continuous CPR with minimal interruptions and allows our paramedics to focus on what's truly important, which is recognizing VTAC VFib and providing early defibrillation. We are also working to equip all ambulances with pediatric iGels to ensure consistency across all pediatric populations. And remember, this change is about doing what is best for our patients. It's about aligning our practice with the best available evidence and maximizing survival where it matters most. If you have any questions, please feel free to reach out to me or Tanner. Thank you.